Press 2 fingers firmly into the skin just above your ankle. Hold them there for 5 seconds and release. Watch what happens next. If the indentation holds, if the skin keeps the shape of your fingers for even a moment before slowly returning to its surface, then what you just found has a name, and the name is almost certainly not what your doctor told you. Over 14 million Americans over the age of 60 live with persistent lower limb swelling, and in study after study, including one of the largest population audits of chronic edema published in the Journal of Vascular Surgery, the primary driver of that swelling is not the heart, but a failure in the system that moves fluid away from your tissues every single day. That indentation that stayed in your skin just now, that is fluid that should have been collected and cleared hours ago. The diagnostic system that greets you in your doctor's office was not designed to find that failure. It was designed around the tests that exist, the billing codes that pay, and the conditions that fill a 10-minute appointment. By the end of this video, you will know exactly why this was never explained to you, and the specific steps the clinical literature supports based on your exact symptom pattern starting today. Subscribe now, because what follows is the biology your doctor was never trained to look for. To understand how that gap opened, you have to go back 400 years to a physician in Pavia named Gasparo Aselli, who in 1627 published De Lactibus Sive Lacteis Venis, the first documented anatomical description of the lymphatic vessels, which he called the lacteals, because of the milky white fluid he observed moving through them in a recently fed dog. Aselli was watching the intestinal lymphatics carry fat-soluble nutrients from the gut directly into the bloodstream, a mechanism so structurally clear it required no inference. Already there, already working. Thomas Bartholin formally named the lymphatic system in 1653. The British physician William Hewson, working in the 1770s, documented that lymph vessels formed a continuous drainage network across the entire body, not only the gut. By the time modern medicine was institutionalized in the 20th century, the vessels, nodes, and drainage function all existed in documented anatomical detail, with clinical relevance to tissue swelling noted in European literature as early as the late 19th century. Here is the first twist. The lymphatic system was described in full anatomical detail before aspirin existed, before the stethoscope was refined, before the pharmaceutical industry was born. Its role in tissue fluid management was not discovered recently. It was documented, named, mapped, and then, over a century, quietly deprioritized in favor of organ-specific diseases that had tests, had drugs, had billing codes, and had profit margins. The biology was not new. What was new, and fatally convenient, was the way diagnostics learned to look past it. Here is what that system actually does. Your cardiovascular system delivers roughly 5 liters of blood per minute through arteries and capillaries into your tissues. That process is pressurized, and pressure is not perfectly efficient. Approximately 2 to 4 liters of fluid leak out of the capillary walls every single day and into the spaces between your cells, carrying plasma proteins, immune cells, cellular waste products, and the debris of normal tissue metabolism. That fluid cannot return to the bloodstream through the capillaries alone. Capillary pressure prevents it. The lymphatic system is the only mechanism your body possesses for recollecting that fluid. Tiny lymphatic capillaries, walls just 1 cell thick, anchored to surrounding tissue by elastic filaments, absorb the interstitial overflow and move it upward through progressively larger vessels, past filtering lymph nodes, and eventually into the thoracic duct, which empties back into the bloodstream near the left collarbone. 2 to 4 liters every single day. No pump drives it. The lymphatic vessels contract rhythmically on their own, a property called intrinsic lymphangion motility, assisted by surrounding muscle compression, breathing movement, and postural changes. Walking is one of the most powerful stimuli for lymphatic flow in the lower limbs. When that system slows, due to age-related changes in vessel wall compliance, sedentary behavior, obesity, infection, or fibrotic scarring, the interstitial fluid that should be collected begins to accumulate, first in the ankles, then the lower legs, occasionally the hands, the face, the abdomen. The pressure becomes visible as swelling, palpable as heaviness, and measurable as the indentation that stayed in your skin. Not mysterious, not rare, and not primarily a cardiac problem. Your body is, at its most fundamental hydraulic level, a drainage system. The cardiovascular system is the delivery infrastructure. Arterial pressure pushes fluid out to every tissue. The lymphatic system is the return infrastructure. It collects what the delivery side cannot reclaim. Both are essential, both degrade with age. But only one has a specialist, a diagnostic panel, and a category on your annual blood work. After 60, lymphatic vessels undergo measurable structural changes. The smooth muscle cells driving lymphangion contraction become less responsive. Valve competence degrades. Fatty infiltration reduces the mechanical pressure that movement once provided. The result is not a sudden failure. Fluid accumulates incrementally, tissue becomes subtly fibrotic, and edema that begins as mild puffiness at day's end hardens over months into a different texture, firmer, less responsive to elevation, beginning to alter the skin. A woman I will call Margaret walked into a clinical practice after seeing 9 different physicians over 6 years. She was 64, swollen since her late 50s, prescribed diuretics at the second appointment and renewed every 3 months since, told at each visit that her heart was fine, her kidneys clean, her veins unclotted. The fluid was still there. It had organized around itself, stiffening the connective tissue, thickening the dermis. In 22 years treating lymphatic dysfunction, I, Dr. James Whitfield, former head of lymphatic and vascular medicine, have never once received a referral with a documented lymphatic workup. What those patients arrive with is a multi-year history of diuretics, a cardiology report showing no structural heart problem, and an ankle circumference that has grown 2 centimeters since their last appointment. The fluid did not vanish, it organized, and the window to manage it had quietly narrowed. Lymphatic failure has a texture most people recognize immediately when it is finally described correctly. The legs feel heavy before they look swollen, a dragging sensation pronounced after sitting more than an hour. The socks leaving deep ridges by late afternoon. The shoes fitting in the morning, pinching by evening. The skin taut, inflated from the inside. In more advanced presentations, the skin begins to change. It thickens. A clinician describing early lymphostatic fibrosis will use the word doughy. Later, woody. Stemmer's sign named after German dermatologist R. Stemmer, who described it in 1976, is the inability to pinch and lift the skin over the dorsum of the second toe. When the skin will not lift, the tissue has begun to reorganize around protein-rich fluid, not edema, a diuretic reaches. A structural change. The time of day pattern matters clinically. Cardiovascular edema tends to improve substantially by morning after overnight elevation. Lymphedema does not clear fully overnight. The morning and evening measurements are closer together than in venous or cardiac presentations. The legs wake up already carrying the fluid they went to sleep with. Not all persistent swelling after 60 has the same mechanism, and this matters enormously, because the interventions that accelerate improvement in one pattern can actively worsen another. There are 3 clinically distinguishable presentations, and you need to identify yours before the solution becomes relevant. Type 1 is primary lymphatic insufficiency with soft, pitting edema early-stage compromise where swelling pits readily and is substantially better by morning. Skin texture is not yet changed. The cause is reduced lymphangian contractility with some venous coinsufficiency, driven by gravity and sedentary behavior. Compression and structured walking almost always improve this presentation. Type 2 is mixed lymphovenous edema with partial morning clearance, the most common presentation in patients over 60. The venous return system is also compromised through varicose veins, post-thrombotic changes, or age-related valve incompetence. Swelling partially reduces overnight but never fully clears. The skin may carry hemosiderin staining brownish discoloration from red blood cell breakdown in the tissue. Management requires both venous and lymphatic support. Type 3 is established lymphostatic fibrosis with non-pitting edema. Press it, and it pushes back. The tissue has reorganized around protein-rich fluid over months or years. Stemmer's sign is positive. The skin is visibly thickened. This pattern does not respond to diuretics. They remove circulating water without touching the fibrotic tissue. Protein embedded in the connective structure and aggressive compression without lymphatic drainage technique can completely worsen the condition by driving fluid into adjacent compartments. Identified your type? Keep it in mind, because what applies to type 1 actively worsens type 3, and the distinction is the difference between recovery and accelerating damage. The first enemy of accurate lymphatic diagnosis is not a person. It is a structure. The International Classification of Diseases, the coding system that determines what a physician can document, what tests can be ordered, and what an insurer will reimburse, contains a category for lymphedema. But reaching that category requires a clinical pathway that does not formally exist in most health systems. No standard lymphatic function test on a routine panel. No lymphoscintigraphy order in a standard workflow. No validated edema screening tool for patients over 60. What there is, a dimer to rule out deep vein thrombosis, a BNP to rule out heart failure, a creatinine to rule out kidney disease. If those three return normal, the pathway effectively ends. The swelling continues. The follow-up note reads, chronic edema, etiology unclear. Continue current management, meaning the diuretic prescribed at the second visit and renewed every 3 months since. In a 2018 audit of patients presenting to UK Vascular Services with lower limb edema, researchers found the average patient had waited 4.3 years from first presentation to correct diagnosis of lymphatic origin. During that interval, the majority had received diuretics and not a single lymphatic-specific assessment. The system was not designed to find lymphedema. It was designed to rule out conditions carrying acute mortality risk. Everything else moved to the back of the queue. Here is the second twist. The deprioritization of lymphatic medicine is not a conspiracy. There is no archived document that reads suppress lymphatic research. What exists instead is a set of incentive structures that produce the same clinical outcome without anyone acting in bad faith. Diuretics are off-patent, inexpensive, and prescribable in 10 minutes. In cardiac edema, where the heart cannot manage the volume it receives, they are appropriate and life-saving. In lymphatic edema, where the problem is transport rather than volume, diuretics remove water from the blood and leave the protein-rich interstitial fluid untouched. The swelling returns. The prescription is renewed. Complete decongestive therapy, the documented standard of care for lymphedema, developed in European lymphology centers and validated in multiple clinical trials, involves manual lymphatic drainage, multi-layer compression bandaging, therapeutic exercise, and skin care. It requires a trained therapist and multiple sessions across weeks, and in most American health systems, it is poorly reimbursed. A study in lymphatic research and biology documented that fewer than 20% of patients with confirmed lymphedema in the United States received complete decongestive therapy as a first-line intervention. The lymphatic system was not disproven. It was made economically inconvenient to investigate, excluded by a reimbursement architecture that rewards symptom suppression with no mechanism for root cause restoration. The physician who never tested your lymphatic function is not malicious. They were trained in a curriculum that gave them no tool to do so. A retired schoolteacher, 67 years old, came through a clinical referral after being dismissed by 11 physicians over 8 years. His swelling had been attributed to aging and sedentary behavior. Clinical assessment found type 2 mixed lymphovenous edema with early hemosiderin staining on both lower legs. 4 months into a program combining compression hosiery, manual lymphatic drainage, and daily walking, the morning circumference of his left ankle had reduced by nearly 2 centimeters. He described that the legs no longer felt like they were carrying something by mid-afternoon. The sensation of drainage is distinct. It is the absence of a weight invisible through familiarity. Then, in 2012, something shifted the scientific frame entirely. A research team at the University of Rochester, led by neuroscientist Maiken Nedergaard, published findings in Science describing the glymphatic system, a previously uncharacterized brain-wide clearance network using the space around cerebral blood vessels to flush cerebrospinal fluid through brain tissue during sleep, clearing metabolic waste, including beta amyloid, the protein most associated with Alzheimer's disease. This was not a refinement of existing knowledge. It was the discovery that the most metabolically active organ in the body had been running its own drainage system for all of human existence, completely unexamined. The glymphatic system operates almost exclusively during deep sleep. Its dysfunction has since been linked in published research to cognitive decline, neuroinflammation, and neurodegenerative pathology. Its discovery restored scientific legitimacy to the broader study of lymphatic clearance. Suddenly, the system was not a niche concern of manual therapists, but a neurological research frontier published in one of the most cited scientific journals in the world. The biology had not changed. The research tools finally caught up. A 2017 survey of American medical school curricula, published in the journal Lymphology, found that the average U.S. medical student received fewer than 5 hours of dedicated instruction on the lymphatic system across 4 years of training. Those same curricula allocate several weeks to cardiovascular pharmacology. The system that moves 2 to 4 liters of fluid daily, that serves as the primary infrastructure of immune surveillance, that produces one of the most common chronic conditions in older adults when it fails, receives less instructional time than a single continuing education weekend. Lymphology exists in Germany, Austria, and several Scandinavian countries as a recognized clinical discipline with board certification, published national treatment protocols, and dedicated hospital units. In the United States, it is not a recognized specialty. The gap is not in the biology. The gap is in the architecture of the system that decides what counts as medicine. Here is the third twist. The proof already exists inside institutions American physicians already cite. Research by NIH-funded investigators on lymphatic vessel biology has been published in peer-reviewed American medical journals for decades, sitting in the same databases your physician searches. What the European clinical application reveals is not a discovery America missed, it is an implementation gap. At institutions including the Felde Clinic in Hinterzarten, Germany, one of the longest-running specialized lymphedema treatment centers in documented clinical operation, complete decongestive therapy, has produced measurable, sustained reductions in excess limb volume. Published outcome data document reductions of 40 to 60% over treatment courses of 2 to 4 weeks, with substantial retention at 1-year follow-up. These outcomes come from manual drainage, compression bandaging, exercise, and skin care, no proprietary components, no pharmaceutical dependency. The cost per patient is substantially lower than years of diuretic prescriptions plus management of cellulitis, a dangerous complication of untreated lymphedema that sends tens of thousands of older Americans to emergency departments annually. A systematic review in the European Journal of Vascular and Endovascular Surgery found that patients receiving appropriate lymphatic management within the first 2 years had significantly better long-term outcomes than those in whom treatment was delayed. 2 years is not arbitrary, it reflects the pace of fibrotic reorganization in untreated lymphodematous tissue. For type 1, the clinical evidence supports structured walking combined with graduated compression hosiery fitted by a trained professional, not purchased without measurement from a pharmacy shelf. A controlled trial in PLOS 1 in 2016 found that 30 minutes of brisk walking 5 days per week produced significant reductions in lower limb interstitial fluid volume in older adults with mild lymphatic insufficiency, independent of pharmaceutical intervention. Calf muscle contraction compresses the deep lymphatic vessels and drives lymph centrally, and correctly fitted hosiery maintains that benefit between sessions. For type 2, the evidence supports adding manual lymphatic drainage from a therapist certified through the Lymphology Association of North America. That referral can be made by a primary care physician. The National Lymphedema Network maintains a therapist, locator, and clinical resources patients can bring to their own appointments. For type 3 established fibrotic, non-pitting edema, complete decongestive therapy administered by a specialist is required. Compression alone is insufficient. Diuretics are contraindicated. The intervention is manual drainage followed by multi-layer bandaging across weeks, with a structured transition to maintenance compression. The barrier is not the evidence. The barrier is the referral pathway, and that pathway can be opened by a single informed conversation with a physician who knows it exists. The lymphatic system Gasparo Uccelli described in 1627 is the same system operating in your ankles right now. The vessels are structurally identical. The lymphangian contractions follow the same rhythm. The 2 to 4 liters of interstitial fluid that must be reabsorbed every single day still move through the same one-cell thick capillary walls, the same thoracic duct emptying near the left collarbone. The biology has not changed. The drainage is still there. The system has not stopped working. It has slowed, under the weight of age and stillness, and the absence of the mechanical conditions it was always designed to receive. But it responds to movement. It responds to compression. It responds to manual drainage. It responds to the conditions it was built for, and it has been waiting, with the patience of a system that does not know it has been forgotten, for someone to finally give it what it needs. This content is for educational purposes only and does not constitute medical advice. Always consult your physician before making changes to your health routine.